Hello, I'm Dr. Akshay Mehta from Nanavati Hospital and Holy Family Hospital, Mumbai. And I have the honor and a great pleasure of having Dr. John Chapman with us. He is the Director Emeritus of the National Institute of Health and Medical Research at the University Hospital in Paris, and a person who has an extensive work on dyslipidemia, especially triglycerides, HDL, LDL, the atherogenic lipids. We heard a wonderful lecture a few minutes ago by him, and we are going to discuss a few things more about dyslipidemia. But before I go into our proper business, I wanted to ask him, Dr. Chapman, you have a British name and you speak English in a pure British accent. And how come you are in France?
Well, Akshay, life is sometimes a story of serendipitous events. And after my first doctorate in London, I moved to San Francisco and subsequently was invited to work in Paris in the 80s, where there was a great deal of interest in developing research, clinical research into familial dyslipidemias associated with premature and severe atherosclerotic cardiovascular disease. So I'm very British.
Okay, that's nice. So it was a work that has pulled you to France. And
yes, absolutely.
What you like.
Yes, and I think in the 1970s and 1980s, this was the period of the discovery of the LDL receptor by Michael Brown and Joe Goldstein, and equally, of course, the development of the statins. And this led to an explosion in the diagnosis of dyslipidemias and ultimately, of course, in their treatment, which over 20 or 30 years has transformed care for individuals with high risk, and I think we have been tremendously successful in saving the lives of many, many individuals around the world during that period.
Okay. So coming to our topic, how common is atherogenic lipids, that is high triglycerides, low HDL, and small dense LDL particles, as compared to pure LDL cholesterol as a cause of atherosclerotic disease? In proportion, what do you think in Europe, for example, or in France? How common, like in India it is very common. So in France, how common is it?
Well, let's make a comparison between the frequency of genetically determined familial hypercholesterolemia, where it's uniquely the LDL that are sometimes also lipoprotein A, but really the LDL cholesterol, which is very significantly elevated. And the frequency from genetic studies across Europe and now in the United States and some other countries is about 1 person in 200. So much more frequent than we originally believed for familial hypercholesterolemia. As compared to familial hypercholesterolemia, the frequency of an atherogenic mixed dyslipidemia, it's almost systematic in individuals with type 2 diabetes. We know that there are, for example, of the order at the moment of 50 million individuals alone in the United States with pre-diabetes, individuals with an expanded waist, with insulin resistance, and with the mixed dyslipidemia you described, and of course elevated cardiovascular risk. So in terms of a population frequency, it very much is related to the frequency, if you will, of overweight, obesity, and sedentary lifestyle and other risk factors. And it seems that in India there is really quite a high frequency of mixed dyslipidemia. It's from discussion with colleagues, it seems to be possibly even 10 to 20% of all Indians who seem to present this much higher susceptibility to type 2 diabetes associated with a mixed dyslipidemia.
Okay. So it's quite high.
It seems to be, possibly even higher.
Yeah. And since is it the cholesterol and the triglyceride itself the cause of atherosclerosis, or it is the particle that is the cause?
Well, it's clearly the particles, Akshay. It's clearly the particles.
Right.
So just so that we clear metabolically,
right,
what the liver does is to make very low density lipoproteins rich in triglyceride. The more substrate we have, the more we ingest fat and carbohydrate, particularly carbohydrate, the more we make triglyceride in the liver, the more we secrete triglyceride-rich VLDL. When we have high triglyceride, we make less HDL, and we make small, dense LDL,
right,
which have a greater facility to enter the arterial wall. So we have a metabolic understanding of the basis for the phenotype of a mixed dyslipidemia, both in diabetics and in non-diabetics. But certainly the insulin resistance is a driver of that hypertriglyceridemic effect associated with the development very frequently of a fatty liver and triglyceride deposition. For example, epicardial fat is well established now in individuals with mixed dyslipidemia. So it appears to be the particles. Now, we know that LDL particles are indisputably associated with driving atherosclerosis,
right,
and we know that in mature coronary plaques there is a high content of cholesterol, mainly cholesterol esters, but equally cholesterol crystals, which are very disruptive to plaque. There is good evidence that particularly from genetics, human genetics, that cholesterol in plaque, in coronary plaque, is directly derived from LDL particles entering the arterial wall, becoming trapped, taken up by macrophages, and formation of the mature plaque. What is new is that we have Mendelian randomization, genetic data in man, for a causal role of triglyceride-rich lipoproteins and the metabolic remnants. They can enter the arterial wall. They contain, particularly the remnants, almost as many cholesterol molecules per particle as an LDL, more than 2,000 molecules per particle. And again, we have direct evidence for the penetration and retention of the triglyceride-rich particles and remnants in the arterial wall. It's indisputable, supported by the genetics. So we really have moved on tremendously in the last 5 years, in part from rapid sequencing technology, the recognition of a much higher frequency of gene variants. We know that hypertriglyceridemia very frequently is polygenic, small variations in several genes, which are exacerbated by sedentarity, smoking, obesity, high carbohydrate diet. All of those factors drive hypertriglyceridemia.
So now we have a very concrete evidence that LDL cholesterol, IDL cholesterol, remnant cholesterol, they all are actual cause. There is no doubt, and the media which hyped that cholesterol is not a cause has a very fitting reply from this evidence that we have. And hence, I think, is there any way that this message can be propagated to the public so that they no more doubt the importance of cholesterol and lipids as risk factors or causative factors? So I think the media has to be more educated about this. Is that right?
Akshay, you make a very important point, I think, because our patients are not as aware as they should be with respect to the importance of cholesterol in the atherosclerotic plaque. So within the last 5 years, we know that cholesterol crystals, crystals of cholesterol in its purest form form in the plaque, and they are disruptive to the plaque. They can rip the fibrous cap, they can create fracture planes within the structure of the plaque under mechanical stress, for example, when the heart rate is very high.
Okay.
So we have a much more direct evidence
Right.
of the role of cholesterol crystals, of cholesterol deposition in the plaque. And this seems to underlie plaque rupture and the thrombotic event that will lead to the partial or complete occlusion, for example, of a coronary vessel or a vessel in the peripheral circulation, in the carotids, or even in the cerebrovascular circulation.
Right. Going to a different angle, since you have done a lot of work on HDL cholesterol, we know HDL cholesterol has an association with inverse association, but it's not a causative factor. So now, how do we, I mean, we know that the efflux capacity or the function of HDL cholesterol is very important. And is the number and the size also important of HDL particles, besides the composition?
This is a really complex question, Akshay, and we'll try to answer it as simply as we can. We know that the smallest HDL particles that we call HDL3, those particles, there are probably more than 1 million small HDL per milliliter of human plasma. So there are very, very many. They are the most abundant particles, lipoprotein particles in human plasma. They are associated with many different proteins and with many different species of lipids. So most importantly, because of the development of omics technologies, DNA sequencing, transcriptomics, proteomics, lipidomics, mostly in the case of proteomics and lipidomics due to mass spectrometric technologies, which are very new and now very precise. So we have been able in the last 3-4 years to recognize that HDL particles are very highly heterogeneous in their metabolism, but almost certainly there are more than 50 different species of individual HDL particles. Okay. We know this because some proteins in HDL are present at very low concentration, but metabolically and biologically very active.
Okay.
One example is the protein we call PLTP, phospholipid transfer protein. Phospholipid transfer protein is present in less than 1% of HDL particles. We do not detect it in HDL cholesterol. We know now that it's an integral part of what we call the reverse endotoxin transport system. HDL plays a critical role through PLTP in binding endotoxin, taking it to the liver for elimination. So there is a totally new therapy being developed for patients with sepsis where we could infuse nanoparticles of HDL with recombinant PLTP protein. And this would be infused in the phase of sepsis to bind and inactivate endotoxin from gram-negative bacteria. So we move now to much, much more particle-specific therapeutic approaches in HDL. So HDL cholesterol has been very useful. It indicated to us that low HDL cholesterol is a major risk factor, no question. But for the future, for therapeutic purposes, we need to target specific HDL particles with specific proteins and specific lipid content. This is the future.
Wow, it's fantastic. I mean, it's so wonderful to hear this, that HDL particles can be used to remove toxins. One very common question that comes up is is any way to improve the HDL function or to measure the HDL function in common practice, and to make it more cardioprotective by raising its levels, or more importantly by improving its function, the functionality, the cholesterol efflux capacity. Can we measure it and can we improve it?
Akshay, again, this is a difficult question. Certainly many of us do measure cholesterol efflux. Again, we know the small particles, the small HDL, are much more active in cholesterol efflux than the larger ones. And there are different mechanisms of cholesterol efflux, ABCA1, ABCG1, passive diffusion, and so forth. So it's not a simple measurement.
Okay.
Yeah? So I think one of the future directions will almost certainly be, as we already mentioned, to try to identify specific HDL particle populations linked to a specific function that appears to be important clinically in a given patient subset or given patient population. So another example is apolipoprotein L1. Apolipoprotein L1 is the very specific inactivator. It's the killer protein for trypanosomes in sleeping sickness. So we can imagine, and it's already happening, a therapeutic HDL particle containing ApoA1, haptoglobin, and ApoL1, a synthetic nanoparticle that could be infused, particularly in Africa, where sleeping sickness is so widespread with trypanosomic disease. We can target trypanosomes. It's very effective.
Wow.
And the last comment I would make is that unfortunately we know that if we play with HDL a little bit too much with the CETP inhibitors, then we can unfortunately attenuate HDL function.
Oh.
So with torcetrapib, for example, we saw in the placebo group, in the torcetrapib treated group, a very dramatic increase in death from infectious disease. Why? Almost certainly because inflammatory proteins in torcetrapib treated patients bound to HDL decreased its multiple biological activities. And this has just recently been reported in Circulation just a couple of weeks ago.
Very interesting, very interesting. Right. So measuring HDL number, does it help?
I don't think so. I think that measuring HDL particles, again, is a non-specific methodology. These methodologies have perhaps been useful, but we needed the science of HDL to move forward, and we're on the cusp. You know, we're like surfing the wave. We're very close to the top of the wave with HDL, with a great deal more information from omics analyses, and hopefully within the next 5 years, we will see arriving in the clinic. Clinical trials are ongoing now, just starting, for very, very new technologies using HDL as nanoparticle vectors for specific HDL-associated proteins for specific forms of disease.
Okay. Do you see it happening, just as you said, the sleeping sickness or toxins, mopping up toxins? Do you see the use of HDL particles for infusion in patients who have atherosclerotic coronary disease?
Again, Akshay, this is a very important question. There have been 2 trials very recently which have failed using recombinant apolipoprotein A1 bound to phospholipid. This is a very, very tricky question because we know when these HDL particles are infused, they immediately change.
Oh.
Some of this work with Dr. Kontush, my colleague, we've published. So HDL is so dynamic. We infuse it, but that doesn't mean to say it stays the same and it has the same functions.
Okay.
So we have to, I think a great deal more.
Okay.
What are we really targeting? And what types of particles and what proteins and which lipids are we infusing in which patient population? So we have to move to another level now in HDL science.
Coming to a simple, we'll just conclude. What about the new things about plant-based diets and vegan type diets or Mediterranean diets for HDL, triglycerides, on reduction of cardiovascular disease?
Well, there is no question that the Mediterranean diet, for example, that was used in Predimed, used in GISI and other studies, that the components of the Mediterranean diet, we mustn't forget fish and omega-3s, together those components were associated with longevity and with low cardiovascular risk in Mediterranean populations. So there's a lesson. These are not purely vegetarian diets.
Correct.
And I think that we must be very careful because vegetarian diets can have high carbohydrate content.
Yes.
I think equally there are specific populations, for example, young females, premenopausal, they need iron.
Right.
Where do we have? We have iron, of course, in red meat.
Meat.
So I think we must think very carefully about the types of diets that we're recommending, particularly to specific populations. We must match them to the dietary needs.
Fantastic. It was a great session to have you. Thank you
pleasure.
so much.
Pleasure,
Thank you,
Akshay.
Chapman.
Pleasure.